In this video, I'll be focusing on the very important topic of palliative and hospice care. In the recent series of videos, I've been focusing on treatment of gastroesophageal cancer in that stage 4 our locally advanced unresectable setting, also known as palliative therapy. And we talked about a whole host of topics, including first line therapy, second line therapy, and third line therapies and later, and the goals of treatment. And we also touched on that most patients receive first line therapy, yet, as patients go through their journey, a number of patients won't be fit enough to receive later lines therapy. You can see about half of patients in most series show that don't go on to get second line therapy, and only about a third of all the original patients go on to get third line therapy, and so on in later lines. And the reason for that, we explained in other videos, is that uh, the cancer in many cases will progress relatively rapidly, and something that we call performance status or strength and ability to tolerate therapy drops. And so that we don't feel that another line of therapy, the potential risks of that therapy outweigh now the potential benefits. So we're always trying to make sure that the potential benefits of a therapy outweigh any potential risks. And so that said, you can see the standard approach of all the various treatments that we have at our disposal through the various lines of therapy. And we talked about one of the main reasons for doing that is that we know that it can improve survival time, and that compared to historically best supportive care with a median overall survival on the order of months, using single agent chemotherapy and then double agent chemotherapies and sometimes even triplet chemotherapies, and then through later lines of therapy, second line and third line when appropriate and higher. And then also an important one, the introduction of biologic or targeted therapies has slowly improved these outcomes, and in some cases significantly, the so-called tail of the curve. But we always, again, are balancing the benefits of that survival advantage and also control of cancer-related symptoms with the potential side effects. And so the notorious balancing act that we're always trying to optimize our treatments. We also talked about that with each line of therapy and ultimately all of our therapies, eventually each of those therapies run their course, the cancer develops resistance in this advanced stage 4 setting, and that we run out of good treatment options, and therefore further therapy at that point is not in your best interest. Sometimes, as I showed you, this happens after just one line of therapy, where that equation of looking at whether the potential benefits outweigh the risks is no longer there. On the other hand, some patients go on and receive a number of lines of therapy, and we've talked about all the various options at each line of therapy, and therefore we proceed and continue that way. Ultimately, even in those settings, generally speaking, we're still going to get to the point where further therapy is not in your best interest. And so we're going to talk about and differentiate between what is palliative care and what is hospice care going forward here. And so the first thing to say is that palliative care, as we'll go through, can be implemented at any time through the various lines of therapy. And I'll show you in the next slides that studies have shown that early implementation of palliative care services, even in first line setting, can improve a lot of outcomes, including quality of life. On the other hand, we'll be talking about hospice care in that setting where we've ultimately run out of good treatment options, or that treatment is considered not in your best interest anymore, even if it's only been one or two lines of therapy. Even though there are other options, it is felt that those options are not going to be likely useful in your particular scenario. So a little bit more about this. So palliative care and hospice care is usually overseen by a palliative care doctor. Typically, they have a background of training in internal medicine, can be from a surgical background as well, but most typically it's an internal medicine doctor. And then they've gone on to do further training specifically focusing on palliative care and with a fellowship. And sometimes, as you can see there, it's coupled with other types of fellowships like oncology fellowships. So you can have an oncologist who's also trained in palliative care and or geriatric care, the care of the elderly. And so the first thing to really address and to really get rid of any confusion is differentiating between palliative care and hospice care. And the common question is palliative care the same as hospice care? And the answer to that is not necessarily. So hopefully at the end of this presentation, we'll really be clear on what these two different terms really mean. So first, focusing on palliative care. Palliative care is a focus on patients with any serious illness, including obviously cancer. And the real focus is on the relief of symptoms from the actual cancer in collaboration with the medical oncologist who's overseeing the actual treatment, the treatment decisions. But as we go through this, you'll see that a key component of this is that, while the medical oncologist is determining how the cancer is behaving and whether it's being controlled well with the current regimen and whether or not treatment needs to be changed, et cetera, and discussing potential risks and benefits of those therapies and coming to a treatment decision in conjunction with the patient and the family. Often in a short visit, they can't really focus on everything adequately. And so this is why a palliative care doctor in parallel seeing you can really focus on symptoms of the cancer or side effects of the treatment, as you see there, relief of stress, from the diagnosis and treatment, often called coping, emotional and spiritual, religious support, and other social support. And you can see that often these are in collaboration with other team members, like a psychiatrist or a social worker, et cetera, to really sort of give a holistic approach and care to the treatment of the cancer. So again, a palliative care doctor is working in collaboration and it's simultaneously in parallel, but really focusing on certain aspects of the treatment of the cancer. Where is palliative care usually provided? Generally, it's provided in the outpatient clinic along with treatments, with visits, maybe sometimes at the same time that you're going to see your oncologist or a nurse practitioner of the treatment team, but also a concurrent visit either before or after on the same day with a palliative care doctor to really focus again on how the symptoms of the cancer, can we do anything to manage that better with medications or other approaches, and how is the treatment and the side effects, and can we do anything to optimize from that perspective. In addition to that, if for whatever reason a patient is admitted to the hospital for example, worsening cancer-related symptoms and or from side effects from the actual treatment, these would probably be the most two common reasons for getting admitted to a hospital during the course of treatment. You would often see a palliative care doctor as a consultation while you're there, sometimes even daily, to again optimize those symptoms with their expertise and trying to control symptoms from the cancer and or side effects from the treatment. They can also be provided if a patient is discharged from the hospital but not well enough yet to go directly home, but at a nursing home, for example, for a period of time, palliative care doctors can visit and provide that kind of care at that setting as well. When we get to hospice, we'll see that a lot of these services are also provided by a hospice in a hospice setting, even by the same doctors, the same palliative care doctors, but less frequently when we're talking about palliative care. Maybe we're talking about once a month visit in the outpatient setting with a palliative care doctor, or occasionally while a patient is in the hospital. Whereas in a hospice setting, these types of visits would be more regular and also as needed, even if daily. So the next thing I wanted to talk about, and I alluded to earlier, is the early implementation of palliative care. And so this study, along with others, demonstrated that introducing a palliative care doctor into the team to regularly see patients can be beneficial. And so what this study did is they randomized patients to getting typical type of care. The oncologist takes care of a patient, and if it comes to mind or if it's really necessary, a patient will then be referred to see a palliative care doctor for a specific reason, called the usual or type of care, or the control arm. And in contrast, in the intervention arm, the other patients that got randomized to the intervention arm had early implementation of palliative care from the get-go, to just get plugged into that palliative care service and to see them regularly. And so you can see in the top left The control group, a lot of those patients never saw a palliative care doctor, the majority of them. And then you can see the numbers of visits that patients had, and very few had a large number of visits with a palliative care doctor in the usual type of care. On the other hand, in the group that was assigned to getting early intervention with a palliative care doctor, a large proportion of them had a number of visits. The next figure shows in B what was typically discussed or addressed in those visits. And you can see a large proportion of visits were focusing on patients' symptoms from the cancer. A lot of patients were discussing coping with their diagnosis with their palliative care doctor. A lot of patients were, especially in the first visits with the palliative care doctor, just establishing rapport with the physician and the palliative care team. A lot of patients were getting further education on the actual cancer diagnosis and understanding what it means and prognosis. And as you'll see also in later slides, a lot of the visits, especially later in the later visits with the palliative care doctor, were about treatment decisions, the palliative care doctor helping to make treatment decisions. And we're going to get to what is advanced care planning and disposition. The next figure shows what types of symptoms were being addressed in those visits. And you can see a very common symptom is pain related from the cancer. Fatigue could be from the cancer or from side effects of the treatment. Nausea, again, can be from the cancer or from side effects of the treatment. Anxiety, bowel issues, whether it's constipation or diarrhea. Often patients that are getting pain medications, a common side effect of the pain medication is constipation. And so we're always having to address that as well. Problems with sleeping, shortness of breath, depression. So these would be common symptoms that the palliative care service is helping the medical oncologist to address and treat. And then in the last figure, we see what types of things are being discussed when we're talking about coping with the diagnosis. A very common discussion is redirecting hope and goals of therapy, counseling about coping, and spiritual and behavioral approaches. And another important thing is addressing familial issues and helping family members also with the diagnosis. So the other important component of this study was to show that those patients that did have early implementation of palliative care tended to have better quality of life quicker. On the left columns, you see it with lung cancer, and on the right with GI cancers. And in the bottom two figures, we see that patients tended to have lower depression scores. And so by early implementation and using these services and the expertise of the palliative care team helped with quality of life and things like depression. And so the idea of introducing a palliative care doctor into the team early has support and is encouraged. So in another study, this really shows what types of things are addressed through the different visits with the palliative care team, from the initial visits to the last visits with them. And as you can see, establishing a rapport, of course, is high in the first few visits, and then later on, you know the team, and so less time is spent on that. But at the same time, there's always a focus on symptoms, with coping with the diagnosis, understanding the illness, and we'll get to advanced care planning in the next slide, but you can see that as time goes on, there's more time spent on this and in later visits, as well as with treatment decisions and also with disposition, meaning when is the opportune time or the right time that we feel that transitioning our goals of care from active therapy to comfort care or hospice care is appropriate. And you can see that, of course, takes place later in the visits as the patient's going through their journey. So what is advanced care planning, healthcare directives, and disposition? I described disposition meaning the time point at which one is considering to transition to hospice. So what is advanced care planning? Well, advanced care planning involves discussing and preparing for future decisions about medical care if you become seriously ill or unable to communicate those wishes. So the first thing to say is, having meaningful conversations with your loved ones is really the most important thing. So they know what your wishes are at any time point, especially when you're not able to relay them to your doctors, and also discussing this with your actual doctors. Many people also, in addition to that, choose to put those preferences in writing by completing legal documents called advance directives. So again, in all of the videos that we've been focusing on in this palliative care setting, we've been talking about our main goal, which is to improve quality of life and length of life, at the same time limiting side effects and establishing balance. And so we talked about doing that through lines of therapy when it's the opportune time to switch to the next line of therapy. But ultimately, as I've been alluding to, we will get to a point, in generally speaking, where we will not have any more effective therapies, or it's not thought that any further therapies will likely help you. And so, if you're unable to change to the next line therapy, or there are no other therapy options remaining, there's no trials around that are you're eligible for, then we'll be talking about a transition or disposition to hospice or comfort care. So, what is hospice care? So, in contrast to palliative care, which can be throughout your treatment, and I didn't mention, but it can even be in the curative intent setting if you're having trouble with side effects, for example, or cancer related symptoms for that matter, a palliative care doctor can still be helpful. Whereas hospice care now is focusing on the care, comfort, and quality of life of a person with a serious illness like cancer who has run the course of all their therapy and is now approaching end of life. And so this generally is talking about a life expectancy of 6 months or less. And, we always say that, but sometimes it's difficult to really know. We don't have the crystal ball, so to speak. But generally speaking, if we're getting to a point where we really feel that further therapy is either not warranted or there aren't any good effective therapies remaining, this is when we're talking about introducing hospice care. Deciding whether and when to start hospice care is obviously a very difficult decision, and it can cause feelings of confusion, being overwhelmed, and so people may choose to enroll in hospice care if the treatment is unlikely to be effective or if continuing it has become too burdensome. So this is what we've been pointing out. And palliative care, as we've been talking about early, can often help with deciding the best time to transition to palliative care and active treatment to hospice. Often this is in direct collaboration with the medical oncologist, who is often discussing this with the palliative care team and the patient and family, saying, we do or we don't have other options. These are the potential risks and benefits. And together we can come to a decision whether or not it's decided on when it's appropriate to proceed with hospice care or not. And so again, by having that team of palliative care doctors involved in your care early, knowing your wishes, knowing your goals, they can help with this decision in terms of making that treatment decision when it is appropriate and the opportune time to transition to hospice. And again, it's emphasized that a lot of the services that a palliative care doctor can provide is the same in the palliative care setting versus hospice care. It may be less frequent visits in the palliative care setting, but notably, it is just a continuation of the same care of that team, maybe a little bit more frequently. And so, hospice aims to provide comfort and peace to help improve quality of life in a person nearing death. And it can also help family members cope with their loved one's illness and can also provide support to the family after the person dies, including help with grieving or bereavement care. And I really want to stress that it really is a convenience for a patient. If we don't have any active therapies that we know can help you, and we don't have any trials available, really we'll be providing this type of care anyway, but it's just more formal and actually can be provided at your home, as we'll get to. And so, for example, having to come to the doctor's office and wait and go through all of that in the setting of where you're not feeling well and you're tired, just to get a script for more pain medicine, for example. This is a convenience thing. If you're enrolled in hospice care at home, the nurse or doctor comes to you and provides you with these things with you not having to leave. So it's a convenience thing. Same thing with providing services like a hospital bed in your home. So it's really a convenience thing of providing the type of care that you need at this time. A common question is this covered by insurance? And so it's important to note that Medicare does reimburse for hospice service when a physician determines that a patient has a life expectancy of 6 months or less. And so that's one of the criteria. And for importantly, Medicare to provide this service, patients must stop any actual treatment intended to cure. In this case, mostly we're talking about to control their illness. So this means no active therapy, chemotherapy, immunotherapy, targeted therapies for the actual control of their cancer. So again, that's why this is a treatment decision when there's no actual therapies available, or it's felt that any further therapy would be futile and not helpful to you or in your best interest. I like to point out here, because this is a common issue, especially in peritoneal only disease that has problems with gut motility and small bowel obstructions and not being able to eat. And sometimes patients are put on total parenteral nutrition, or TPN, so giving nutrients through the vein in an IV. And so this can help to prolong life because now you're getting nutrients that otherwise you'd not be able to have. And so it's a tricky situation because technically hospice care does not allow generally TPN. And so this is a common discussion, is if a patient has already started TPN, whether or not it's appropriate to stop in order to proceed with hospice. And again, this would be in collaboration and discussion with the palliative care doctor, the medical oncologist. So hospice care, where does one receive hospice care? So as you can see there, it's essentially wherever a patient is living and able to be provided with this care. So mostly it's provided at home hospice, but it can also be called inpatient hospice, like in a hospital if a patient is really acutely ill and the degree of help at home would not be available. So many patients choose to receive hospice care at the home so their friends and family can visit as they wish. And other considerations when you're deciding where hospice is going to be provided is whether it's at home or versus one of these other settings, is the cost and the stability, as I was mentioning, of the patient's condition and the ability of, say, for example, at home, the family to really take care of them or not. And so choosing where to receive hospice is ultimately a personal decision, but obviously helpful to discuss with family members, your caregiver, your doctors about the level of care you would need, and the social worker as well to help with placement, especially if it is at one of these other places like a nursing home, living facility, or in a hospital. Ultimately, sometimes decisions are made based on the costs of where the hospice care is going to be provided because the cost at these various facilities may differ. Importantly, while some think that hospice means 24 hours a day, 7 days a week type of care, generally this is rarely the case if it's at home. Although hospice provides a lot of support, most of the day-to-day type of care of a person is provided by family and friends when you're at home hospice. That said, a person from the hospice care team, a nurse or a nurse practitioner, etc., is always available and can come on an as-needed basis for any issues. So importantly, studies have shown that when a person has enrolled in hospice care, they're more likely to have increased family satisfaction and better symptom and pain management. And importantly, they're less likely to undergo tests and be given medications that they don't need or want, and less visits to the hospital. Usually, the overall care transitions to the palliative care team and hospice team of doctor, but the medical oncologist who had been with you through your journey is always available and usually available if needed, but won't be making the day-to-day decisions at that point. So to summarize and contrast the difference between palliative care and hospice care, this is a nice table I pulled off this website. And so you can see, and as we've heard, there's a lot of similarities between the two services. What they both have, they both are intended to help people improve quality of life with serious illnesses by addressing pains and symptom relief from the cancer and side effects from the treatment. There's an interdisciplinary teamed approach in either situation, meaning there's the medical oncologist team, the palliative care team, and others. It lowers the cost than an actual inpatient hospital and facility care by having these types of services involved. And it really importantly helps avoid unnecessary trips to the hospital and the emergency rooms in the middle of the night, for example. And of course, either service can be tailored to patients' needs and wishes. And we always would be working with the patient's primary physician and primary oncologist. However, of course, there are differences between the two. Palliative care in terms of coverage may or may not be covered by private insurance and Medicare, Medicaid, depending on which state, whereas generally speaking, the hospice care, when appropriate, is covered. Palliative care is really in any stage of disease and can be at the same time of curative treatment or through a full-length journey of palliative therapy in the stage 4 setting. Whereas, as we noted, hospice care is in the setting where further active therapy for the cancer itself is no longer considered appropriate, and those types of therapies, whether curative or to control the cancer, have stopped. The length of care depends on the needs and the insurance in the setting of palliative care. It can be relatively infrequent visits with a palliative care doctor through a number of lines of therapy just to touch base, whereas the length of care is really with 6 months or less in the setting of hospice. One thing to note is that, for example, if a patient is enrolled in hospice and we get to the 6-month mark, it would just be extended because obviously, as I mentioned earlier, sometimes it's hard to gauge survivability. Sometimes these numbers are hard to predict. And so if for whatever reason the patient is living longer than that, that's great. And it can just be extended if hospice is still appropriate. Where the palliative care is provided, as we talked about, usually delivered in the hospital when a patient is admitted for acute issues, side effects from therapies, worsening symptoms from the cancer, but also, as I mentioned, can be regular outpatient visits in the clinic. The hospice care, as we talked about, would be decided wherever the patient calls home, and that can be provided in that particular setting. The palliative care does provide some support for family and caregivers, but obviously it's more comprehensive in the hospice care setting, and similarly with some emotional and spiritual support for the patient and family, whereas this is the main sort of component of hospice care, is to provide that holistic comfort care, including emotional and spiritual support. So in this video, it's a really important video for patients that are in the setting of palliative therapy, in the setting of stage 4 gastroesophageal cancer, who are embarking on a journey of palliative therapy to try and improve quality of life, decrease symptoms or delay the onset of symptoms from cancer by getting active therapy, but can still get palliative care services to help optimize that by optimizing medications and other strategies to address those issues during the treatment phase, but also transition to hospice care when the time is appropriate, whether that is because further therapy is considered more futile, even though there are other options available, but it's felt that more therapy really is not in your best interest, or there truly is no further effective therapies available because you've tried all of them and we've exhausted the whole list of active therapies that are known to us. And so importantly, the ideal time to transition from a palliative care setting and active therapy for the cancer to a hospice comfort care setting is a big decision that you do have people from the various teams, including the palliative care team and your medical oncology team, to help you with those decisions. Thank you for your attention.